Hello, hello. How are you doing? Well, first of all, how are you doing, everyone? So welcome, welcome. Thank you so much for hanging out with the IOCDF today. If you're not familiar, this is the International OCD Foundation. We are the largest and most international nonprofit that supports people with obsessive compulsive disorder as well as related disorders. And we do these live streams weekly. And the live streams have a couple different purposes. One, to give you education, disseminate up-to-date research, have guests on that are really kind of important to the moment, but also to answer your general questions, advanced questions. We're just here to offer education, but also support and community to know that you are not alone. So you may be joining us on a multitude of platforms. In the chat, in the comments, people are putting comments from all over the world, as well as from all different social media sites. And so people can absolutely ask questions, comment, support each other in the chat. So while you're watching this, if you have a question for myself or our guest, definitely ask us a question and then we'll go ahead and answer that. Always a reminder, this is definitely trying to be as safe as we can and as respectable as we can, but it's also cannot replace emergency therapy. So if you're in a crisis, you're really struggling, please dial 988. You can go to 988lifeline.org or go to your local emergency care or connect with your psychiatrist, your prescriber, or your clinician. But today we have a special guest. I'm excited. My name's Chris Trondsen. I'm a licensed therapist here in Orange County, California. I treat OCD and related disorders like body dysmorphic disorder, but I also have OCD. So it's been a full journey for me. Super excited to always host these lives. Like I said, answer your questions, bring in community. But we have a special guest today, all the way from USC, my good friend, Adam Frank. So I don't have your official bio because I know you, and I was like, I don't want to sound robotic. But Adam is a good friend. He is on the board of OCD Southern California with me. So we see each other often, monthly, at least for our meetings and stuff. But he's a psychiatrist in Los Angeles. So tell me a little bit about like what got you into the field, what kind of gives you that passion, what you're working on, and just a little bit of background for the folks.
Yeah, thanks, Chris. As you said, I'm a psychiatrist at USC. I treat and specialize in treating OCD and related conditions. I also spend a lot of my time doing research on OCD, trying to understand sort of causes of OCD, how we can improve treatment outcomes, how we can personalize treatment for individuals. And I have experience with neuromodulation techniques as well. So things like transcranial magnetic stimulation, TMS, things like deep brain stimulation or DBS. And for me, really, I there's such a need in the OCD community for access to high quality care and for development of new treatment approaches. And that's like, it's just gratifying to be able to like participate in this community and then help to sort of generate these new approaches to treatment.
Yeah, and you're good friends with a friend of the show and a friend of the community, Barbara Vanopin. So I know she probably had a little bit to do with like reining you in to focus on OCD, or did you already have that passion ahead of time?
It was a mix. I had some experience with OCD previously, and then Barbara has been a real champion here in Southern California and broadly for the OCD community, and helped to kind of plug me in a little bit as well.
Yeah. Okay, no, I know Barbara's like her kind of like mission is to go and like get people involved. So I always double check. If you're joining us, if you just joined us, please feel free to say where you're joining us from the chat. Just let us know where you're joining us. We have people all around the globe, so we want to hear where you're representing from. And then who are you here to support? Are you here to support yourself? Do you have a partner or a loved one with OCD or related disorders? Are you a therapist? Are you a professor? Love to hear where people are coming from. So we have a bunch of pre-submitted questions today, Dr. Frank, Adam. So I am going to start and jump into those in a little bit, but some general questions we always have for psychiatrists. How do people know medication? First of all, is medication typically the first stop? And then when do people know like, hey, medication is probably something I need if I want to recover from OCD? Because I know some people don't need it, some do. So how do people, is medication still kind of like the first line treatment? And then how do people know like, hey, I should probably be on some medication?
Yeah, great question. I think there's a few factors that I consider when thinking about whether medication is something that we should have in that treatment plan. One is sort of how impactful, how severe is OCD when somebody's sort of trying to get connected to treatment. If OCD is relatively mild, there might be other treatment options that we could consider before going to medication. Those other treatments are things like evidence-based psychotherapy, so things like ERP with cognitive behavioral therapy. And many treatment guidelines suggest if OCD is mild and ERP is available, that might be the right first step for people to try to get connected with a therapist and participate in again evidence-based therapy before trying medication. If somebody's got more severe OCD, or they have OCD with depression or with sort of generalized anxiety, that might be a time to consider starting with a medication or having a medication available while somebody works to get connected to an ERP therapist. Sometimes ERP therapists are really hard to find. I think it's improved, sort of post-pandemic, as more and more people are participating in telehealth, and the availability of that has increased. But still, sometimes it's hard to get connected. And so, if ERP isn't available, then medication might be another reasonable first step in that kind of treatment algorithm.
Yeah, I always say people are unsure like what that looks like and what should people be expecting from the medication. And you could answer this along the path, but a lot of times when I work with people and they've been on medication for a couple years, sometimes when I ask them, do you feel like the medication's working? The answer I get a lot, not always, some people they're like, yes, it's working really, really well. Before medication, I could barely function. But some clients will say to me, like, I don't really know. I've been on it for a long time. And like I don't even know if it's the medication or if it's the treatment. So what is a realistic, like, if I'm waking up and let's say previously I was dealing with just constant like intrusive thoughts, dealing with rumination consistently in fear, misscanning, thinking I mean, if that's like the predominant part of my life, if I'm on medication, I've been on it for like that 12 weeks, 15 weeks, what is a realistic expectation in recovery if I only took medication and didn't do any kind of treatment?
Yeah, it's an important consideration. Like, what should we expect from any of these treatments that people are going to participate in? From the medication side of things, I usually, as I'm having this conversation with individuals who are considering starting medication, like, what could we expect early on, after you've been on it for a while, and sort of longer term? Medication isn't going to cure OCD, and it usually doesn't make it go away completely. It can be helpful for sort of turning down the volume of OCD. So the like frequency of intrusive thoughts, the intensity of intrusive thoughts, that volume can kind of like be turned down a little bit with medication. And often sort of an individual's like emotional reaction to those intrusive thoughts. Like, I'll often hear, they still happen, but they just don't bother me as much. They're just not as like loud or intrusive. So those are from an OCD perspective, the things that we're hoping medication can be helpful for. Again, if somebody's dealing with co-occurring depression or generalized anxiety, there may be other benefits to medication in terms of helping with like mood and anhedonia and sort of normalizing sleep and other things that can come along with depression or anxiety. But from an OCD perspective, I really think about sort of like just turning that volume down on symptoms.
Yeah, you know what? For everybody watching the live, you can definitely ask questions or comments about medication, but you can also ask general questions about therapy, about the kind of connection. And what I was going to jump in as a clinical side is people ask me the same question, like, what should I expect from treatment? And then treatment with medication. So what I always tell people is the good thing about OCD treatment is it's fast acting. Now, ERP can be difficult. So somebody has to be in the mindset to do it, because really what we're asking someone is like, hey, there was a set of behaviors and mindsets and belief systems you had before the disorder really hit. And because of a lot of fear, you sort of cranked it, almost done like a 180, and your life looks a lot different. And so we're asking you to kind of reconnect with the things that mattered previously. And anytime we push back against things that cause us distress, there's going to be some turbulence, there's going to be some difficulty, but it's also a pretty fast acting treatment. We also use different CBT strategies, different ACT strategies, mindfulness, and motivational interviewing can absolutely be helpful. Sometimes DBT to help regulate emotions. But ultimately, as you start to do the treatment, it is quick working in the sense that if you've been with a clinician and you've been really working hard at the right level of care, in 3 to 6 months, you should see a significant drop. And I know in medication, after about 3 months, you should see a drop. So what I see, and maybe you could answer it, what you see on your end is like when somebody's on the right medication or TMS or whatever they need, and they're really doing treatment. I mean, this is where like 6 months later, maybe somebody's starting to volunteer or go back to work. They're noticing that like their morning routines and their night routines are quicker if they have contamination, or if they have religious scrupulosity, their prayers have reduced, or, they're starting to like say yes to things, maybe go back to school, starting to become more independent, and overall feeling less on edge, more relaxed, more focused, and happier and reconnected with self. So that's kind of what I see on my end. What do you see on your end if somebody's on the right dosage or the right neuro intervention, or really doing the work like 3 to 6 months later?
I think that this is what gets me out of bed in the morning. It can be so gratifying to see that like 180-degree change from like somebody who has a hard time leaving the house, doesn't interact with friends or family, and with connection to the right treatment and as you said, like 3 to 6 months for some people, that can be life-changing. I do think it can be really helpful to also be then connected to a therapist because, as you're pointing out, Chris, sometimes these behaviors become really entrenched and routines take up so much of the day. And as those start to improve, people are like, well, now what do I do? Like, how do you re-engage with other people, with the world, with things that you actually enjoy? And that's where, connection to a therapist can really help with figuring out, how do I get back to doing those things that I like to do now that I actually have the energy and the motivation and the time to do those sorts of things. So I would say, yeah, for people who medication and therapy are helpful for, can be really transformative.
If somebody isn't connecting, or if somebody isn't responding rather to a medication, like I know on my end, right, on a clinical end, if I'm working with a client once a week, or what I have sometimes is I run support groups, and there's people that whether it's finances or time or for whatever reason they can't access care, and so they're just coming to the support group as like their front, their treatment. I know on my end, like I can identify like, hey, this isn't the right level of care. You're really struggling to sort of like take the work that we're doing in session and practice that in between sessions. I only see you 50 minutes a week, and there's hundreds of hours, right, struggling and getting that person the right level of care. So there's a lot of things we can do. Sometimes clients respond much better to the cognitive side of the treatment, sometimes the behavioral side, sometimes it's slowing down and just kind of educating them what's going on in the brain. I hear a lot of times, sometimes people will say like, oh, well, I've tried medication before and it didn't work for me. Like, what should that look like before? I know for me on my end, where it's like I refer to a residential, where it's just like there's so much going on, there's co-occurring stuff. They can't do their normal like getting ready in the morning, their general behaviors. They're not eating, they're not sleeping, they're not brushing their teeth. Like
Mhm.
they need an overhaul in life. And I just can't be with that person that many hours a day, like a residential. How do you know, like, hey, somebody's really tried as much medication and they're just not a med responder?
Yeah, it's important consideration too, is like what sort of intensity of treatment is likely to be helpful if somebody's really struggling with sort of day-to-day activities, and the most treatment they're accessing is a 50-minute group with you, once a week. It's unlikely that that's going to be sufficient. And so thinking about like, what are those different levels of care that people can access, and sometimes residential or PHP, where people are living in an environment that's supportive 24/7, or going to a program for 5 to 8 hours a day, 5 days a week, that can really be important in sort of jump starting treatment. From the sort of medication side of things, and thinking about, is somebody a responder or a non-responder, we know from many studies that with OCD, sometimes we get additional benefit from higher doses of the first line medication, so SSRI medication, things like Paxil or Prozac or Zoloft or Lexapro. And sometimes the doses that we would use for somebody who had generalized anxiety or had depression and didn't have OCD are lower than what we'd use for an individual with OCD. And sometimes people don't get to those higher doses. They're getting medication from, maybe their primary care doctor who isn't aware that it can be effective and safe to go to these higher doses, or their prescriber doesn't know sort of the literature around treating OCD with medication, and so people get to like a middle of the range dose and say, well, it's not doing anything for me, I'm a non-responder, and never get to that higher dose where we might actually start to see some benefit. um, all of the SSRIs work equally well, sort of at a population level. But for a given individual, I've certainly seen that some people don't have much of a response to one SSRI. And if we try a different one, that can actually be more helpful for that person. And sometimes all the SSRIs have slightly different side effect profiles. And that's one of the important things that we consider when we're thinking about, if somebody's never been on an SSRI before, which one do we start with? Well, what are the side effect profiles? Are there things that might actually be a benefit? So if somebody's having trouble sleeping, some of the SSRIs are a little bit sedating. So we might actually get benefit from the sleep perspective as well as from the OCD perspective. So we think about sort of the side effect profiles, and some people respond differently to those. And so if somebody's tried one SSRI and it hasn't been effective, or they've had some side effect that feels intolerable, there might be another option within that family of medications that could actually be helpful that doesn't have that exact same side effect. And sometimes people will try, sort of one medication. It's like that didn't work at, an inadequate dose, or not taking it for long enough, or the side effect was bothersome, and then think, well, I can't do any other SSRI. And that isn't the case. There are other options.
Yeah. I have a bunch of different questions we have pre-submitted, but we have some live that I want to throw up first. So thank you to everybody that's making your comments and questions. Nathan Rice at 12:12 your time, Emilio, says Prozac made OCD go away completely temporarily. I hear that sometimes from clients. So I wanted you to kind of like address that. Like some clients will say, oh, I used to be on Prozac and my OCD did so well. And then sorry, my light fell. So then I went off of it, and like, now I've gone back on and didn't have the same effect. Or some people will be like, oh, I was on medication for a while and then it just stopped working. Can you talk a little bit about that? Like, if people go off of medication, could it potentially not work the second go around? Do medications sometimes poop out? What usually leads to a situation like that?
Yeah, I think I appreciate Nathan for sharing your experience, and I think everybody has a little bit of a different experience. And for some individuals, medication works and medication keeps working. There are some studies to suggest that for people who have engaged in treatment with medication and with therapy and have done well, like OCD is in a much better place, that after a certain amount of time, usually on the order of like months to maybe a year or so, a lot of people, up to half of people, can slowly taper off of their medication and things stay in a really good place. For that other half of people, OCD can start to creep back. And so there can be a role for some individuals for medication to be an ongoing treatment component, and can continue to be helpful for some people. For some people, they'll notice that if they go off and try to go back on, that it doesn't seem to have the exact same benefit that it did the first time. And that may be a dose adjustment thing. We might need to explore higher doses of the medication, but not everybody has that. Some people certainly can go off and then come back on, and things go really well that second time. And there is this concept of medication poop out. Sometimes the technical term is tachyphylaxis, meaning it, like, over time it seems to have sort of less of a benefit. This is a bit more sort of recognized in SSRI medication for depression in particular, but occasionally this can happen with OCD. And there again, I would suggest we've got a whole bunch of different SSRI medications, worth exploring a different one if you're feeling that hasn't been helpful. Going back on the same one isn't helpful, or it's starting to feel like it's wearing off. And then there's augmentation strategies. So other medications, other classes of medications that can be added to try to boost sort of the effectiveness of SSRI medications if you're not feeling like they're fully effective.
Thanks, Adam. I'm going to take a question from Brendan Beard. It's a kind of a two-part. I'll take the clinical part. Brendan says, I take Effexor for depression. Can I effectively treat OCD with not responding to my intrusive thoughts? So the part that I want to ask you, Adam, before I take the second half is Effexor a medication that works also for OCD? Is it typically just for depression? Walk that kind of line, because sometimes people will have depression and OCD. Does a medication like Effexor help for both?
Yeah, so Effexor is the brand name. Venlafaxine is the generic name for that medication. That falls within the SNRI class of medication, serotonin and norepinephrine reuptake inhibitor. Um, there is evidence that Effexor can be helpful for both depression and for OCD. It isn't generally considered our sort of first line for OCD. Again, those are medications in that SSRI class. Again, like Lexapro, Zoloft, Paxil, Luvox, Prozac, Celexa. I think that's all of them. Those are sort of our first line, but sometimes people end up on, for instance, Effexor for depression, and then get a diagnosis of OCD or get started on that for both, and there is evidence that it can be helpful for OCD and for depression.
Yeah, and Brendan, I'll take the second part of the question. So when people have intrusive thoughts, people with OCD, when we look at the DSM, that's like one of the big factors of the diagnosis is people having those unwanted intrusive thoughts. They often feel very jarring. They're usually connected to something you really care about. So let's say you're a new parent and you really are afraid that you're being too kind of irresponsible and you could potentially do something to harm your child. So you leave something on the floor, they choke on it. And obviously I call it the range of normalcy. Like every new parent is going to be pretty cautious. They're going to get the baby gate. They're going to read all the ingredients. But I always remind people that last D letter in OCD is D. So it means it's disordered. It's causing distress. You can't sleep. You're waking up early. You're inspecting the house. You're thinking about it. You're asking people reassurance. And so what happens is if we I call it the runaway mental train, right? If we kind of go on that runaway mental train where all day we're sitting there and we're coming up, I call them like these what if like scenarios. We're coming up with all these what if potential scenarios. And there's some research out there that people with OCD tend to get caught up a lot, and it's called absorbable. They get consumed and absorbed a lot more in their imagination. So people with OCD as a parent could be coming up with all these imaginative stories of like how their child's not going to be safe in their care, and they're going to feel those feelings of angst, but also maybe some guilt, and start to do those actions. The problem is every time we give those conversations validity, those intrusive thoughts about what if questions about potentially being harmful to your child, we're reinforcing that. And think about how things work, right? Like I don't drive in the carpool lane solo because I'm going to get reinforced that that's bad because I'm going to get a ticket. And I don't want to get a ticket, and I don't want to have to pay the ticket. But if suddenly tomorrow they said, you know what, you're not supposed to drive in the carpool lane as a solo driver, but we're no longer going to ticket, I would be in that carpool lane tomorrow, right? Because I wouldn't get a ticket. It's not being reinforced. And so if your what if intrusive thoughts, coming up with all these kind of what if scenarios and stuff, and you're starting to get really like imaginal absorption, you're getting super caught up in like these what if scenarios, you're playing it out. Maybe you could answer this question. I mean, I feel, because I live with OCD, Adam, it's like I know I'm more impacted by, like, when I was a kid, I could like come up with these like scenarios in my head. They were fun ones, and I could like get consumed in it, right? And so I see with my clients, they're in their head, they're coming up with these what if scenarios, they're super absorbed in that imagination, they're creating all these what ifs. And Brendan, if you're giving every single possibility your attention, your validity, your rumination, your constant trying to solve and fix, your brain thinks it's valid danger you're in, kind of like the Hunger Games, and it's going to keep it coming back. So one of the things that we work on with exposure with response prevention, a type of cognitive behavioral therapy, is learning how to have those intrusive thoughts, but not engage. And some of those what if scenarios may come true. People are like, oh, but what if I'm, not cautious enough and my child gets hurt? Kids do bump into tables. Kids do, knock over in the table, right? all we can do is do a certain level of control to be safe. And after that, there's not much we can do. So coming up with all these scenarios and trying to prevent everything from happening is just not realistic. You definitely, though, just because you have OCD doesn't mean you can't take care of your child. But what we're saying is like really working on like letting a lot of it go and accepting that there are some scenarios that we don't want to happen, and trust you'll land on your feet and be able to handle it. But do you see that with your because I know you probably prescribe to people without OCD. I mostly only see OCD and BDD, but I feel like people with OCD can get so absorbed in like the thoughts, the feelings, and get consumed by it, even if they're like sitting in front of TV and relaxing on a Sunday.
Yeah. And I think you bring up an important component, Chris, that like sometimes the intrusive thoughts, the sort of like absorption into those makes it hard to engage in ERP. It's like it's hard to try to do that work, to sit with those uncomfortable thoughts and be okay with the what if. And sometimes that medication can have a role there, as I said, in sort of like turning that volume down so people feel better able to like participate more fully to get sort of the maximum benefit they can out of ERP. So I certainly think that can be a helpful combination for some people who might not otherwise be able to actually like sit through a therapy session.
Yeah. I'm going to get right back to the more live comments and questions, but I wanted to get to some of the pre-submitted because we have a lot. Someone said, hi there, can I ask a question about SSRI medication? When they say it takes 8 to even 12 weeks to start working, would that be about the same time it would take per dose increase if you were starting on a new SSRI medication? So what I think they're saying is like, let's say Prozac, right? They start on 20 milligrams. Does it take that 8 to 12 weeks for it to like hit the 20? And then 8 to 12, then you go on 40, 8 to 12 more weeks, or what does that timeline look like?
Yeah. So no, we're not usually waiting 8 to 12 weeks before dose adjustments. We're, obviously working with the individual who we're doing the prescribing for to see how they're tolerating it. But we can certainly make over, days to a few weeks, we could get people from that 20 up to 40, 60, 80. I have some people that are on like 100 of Prozac. Again, we're doing that thoughtfully and checking in terms of how, whether side effects are coming up, what those are, how bothersome they are, is there benefit that we're starting to notice. A full course of an SSRI for this 8 to 12 weeks should be at that therapeutic dose. So we should try to get to, the 60, 80, the 100 of Prozac, and then give that 8 to 12 weeks to see if we're getting benefit there. So we're not slowly titrating over that time and then waiting and then doing, a dose adjustment and then waiting. It can be a little bit faster. Not everybody takes 8 to 12 weeks to have a response. Some studies show that even within the first 2 to 3 weeks, we might start to notice subtle changes to sort of the severity of OCD symptoms. That's a good sign. If people are noticing within that first month or so that they're feeling some difference, some improvement, that suggests we're going to continue to get benefit over that longer period. But I wouldn't give up hope if you're not, you got started on something and it's 2 or 3 weeks and you're like, I'm not sure it's working, I'm not noticing anything. Keep at it, because for some people it does really take that 2 months, 3 months to have the maximum benefit.
Well said. I'm going to go back to, it's more of a comment, but I want to get the medication side and I can ask the clinical side. But at 12:15, Jane Taylor says her life lately has been pretty brutal. She's had a grief over the sudden loss of her spouse, depression, and rumination. I'll talk about the rumination side, but let's say somebody is your patient, they're taking medication for OCD, and then like Jane, they have sort of a life experience where they're dealing with loss in their family. They're really struggling. What I've always been curious about is if the medication originally, let's say they weren't really showing depressive symptoms, and the medication originally was really to hone in on OCD, would in a time like this, would you go up slightly on the medication? Do you not really touch it? I know it has to be more of a case by case, but in general, if a client comes in, they haven't shown signs of depression, only OCD, but they're going through a lot of hard times. Can you up the medication? How does that work in kind of those real life experiences?
Yeah. Jane, sorry to hear about that. I would say if somebody is going through challenging times and there's prominent loss, and somebody's experiencing grief, I generally don't approach grief from a pharmacotherapy perspective, right? Grief is a natural human experience, and something that I hesitate to sort of pathologize and say we've got to put you on medication to deal with your grief. It's really painful. But if somebody's already engaged with a therapist, great, because then you can do a little bit of sort of grief work with them as well. If the grief sort of extends beyond that kind of typical experience that people can have in terms of loss, and does actually then become sort of depression, there are approaches that we could take if somebody's already on a medication, and that depends a bit on sort of what symptoms of depression they're having. If they're already on an SSRI medication and now they're having difficulty with energy and focus and motivation and anhedonia, we could consider upping the dose of the SSRI medication. If it was initially prescribed for OCD, they may already be on sort of the higher end of a dose that is above what we might typically use for depression alone. Another option would be to add an augmenting agent, so something from a different class of medications that could target some of these other symptoms of depression. In the sort of example that I gave, one option might be something like Wellbutrin, where it's acting on sort of a different neurotransmitter system. It comes from a different class of kind of antidepressant medications and could be helpful in terms of like energy, motivation, focus, those sorts of things. So I think there might be a few options if it really is beyond just grief and is moving into sort of like grief with depression.
Yeah. What I'll say on the rumination side, Jane, is one of the tough things is you're going through some stuff in your life that's already difficult, right? And the rumination, the OCD component of it is just going to make a tough situation more tough. And I that's what I try to tell clients is like, just because you're in OCD treatment and you have OCD doesn't mean that you cannot experience normal human emotion. If anything, what I want you to be able to do is grieve without OCD. Because what I'll see is like clients will come in and let's say it's a loss of like a person's life or a pet or a breakup, and they're just spinning. And it's like they're not really getting to like process their own thoughts, their emotions, and grieve because they're stuck in this kind of rumination tunnel of like what if questions, or I should have did this, or it's not fairs, and all those things. So what I tell clients is what I really want you to work on is like, how do you get to have your normal human emotions and pull back on the rumination so that it's not just adding more. So that would be one thing I'd suggest to work with your OCD providers. Like if the rumination is compulsive rumination that we see in OCD, because I see that, right? Like I've seen people like lose their mom and it's like, why didn't we, she was sick, like why didn't we do this? Or I found this one hospital that they're doing cutting edge research, why didn't we do? And it's like they're just beating themselves up and doing all these kind of like should have, could have, would have scenarios that their OCD is having them roll out, but they're not getting to tap into like their emotions and how they feel with the loss of a parent and how are they going to move forward. So OCD just makes life worse. I'll take this next question, but if you have anything to add, Adam, you totally can. Croft says at 1218, could OCD impact somebody's ability to manage money or hold property? Following our child's diagnosis, we aren't sure whether we need to change her inheritance to a trust to protect her in the future. I mean, that really depends. There are definitely people. My mom and I run a very large family and loved ones OCD support group, and we talk to some of the parents in that, and they may have an adult child that's living at home, that's not working, that's not taking care of themselves and are kind of refusing treatment for the moment. And they're afraid that if they passed away, that their loved one would have this money and like either spend it compulsively or just not know how to manage like those ADLs, those everyday, kind of things that we do in living. So what I would say is I wouldn't immediately change something because your child has an OCD diagnosis. And I think a lot of it has to do with their age. But what I will say is like sometimes somebody who is in their late 60s, 70s, and has like a child in their 40s or 50s that is just not able to take care of themselves and kind of refusing the treatment they need. Some parents might figure out a way that if they do pass away, unfortunately, that their money is going to be done in a way that that adult child is still able to take care of themselves, have a home over their head, etc. So if you don't think your loved one could do it, but let's say your kid is 19, I wouldn't change anything. If anything, what I would really work on is trying to get them some treatment, because that's going to be more helpful. I'll answer this on a clinical side, but I want to ask you this for the medication side. Is there a specific approach? This is from Marco at 1218. Is there a specific approach to therapy like CBT or ERP that is recommended if a patient has a co-diagnosis of ASD, so autism spectrum disorder? Is the medication the same? Do you find that something like TMS or deep brain stimulation or these other interventions are better for people with ASD, or is there not much of a difference when it comes to medication?
Yeah, I think we would want to consider is there anything co-occurring with the ASD and OCD, excuse me, that we would target with medication. But in general, the approach would be the same from the OCD perspective. If somebody had ASD, we wouldn't jump to a different treatment modality like TMS without, trying our standard medications and therapies.
Yeah, I would say, Marco, on the clinical side, there are definitely changes that I make when working with someone with autism, but people who are autistic are all different on the, different, levels on the spectrum. So for some people, I don't make much changes at all. For other people, they, like I was working with a client with autism for my last intensive outpatient program, and habituation model just was not connecting. It just took a lot of time to habituate, and it wasn't really helpful for them at all. But what was really helpful was like learning why the behaviors that they were making were causing certain distress in their life and being open to making those changes. So we did a lot more cognitive work. We did a lot more talking about like why what they're doing is probably not helping them with their goal, like reaching their goals. And so I think it's a case by case situation. But I will say, like, for clinicians that are trained in more of a classical ERP, this phone is contaminated, hold the phone until you habituate 50% and move on. What I have found just clinically is for a lot of people with autism, that doesn't always work. Also, sometimes, we sometimes ERP therapists or OCD therapists in general, rather, are known for being like anti reassurance, but sometimes therapists get too, tight with that. But for instance, I was working with a client that was using, I don't know if do you know Fabuloso? The cleaning agent, the
Purple
purple.
Fabuloso,
I
yeah.
don't know if that's a thing in like the rest of the world, but like in California, we have this Fabuloso. But unfortunately, I had a client bathing in that, and it's a harsh chemical that you clean floors with. And for them, being kind of like, well, we don't always have answers and stuff, wasn't really working. What really worked for them is like we went on the site, we looked up the research, it showed it can cause cancer, kind of more of like that education. Or they were putting like overflowing clothes in the laundry, and and instead of being like, we'll use less and take a risk, it was really a lot of education, like, hey, this is how an agitator works in a washer, this is why it's not working. There was still obviously contamination OCD there. So I think working with a clinician, I think, Marco, the best way to answer this would be working with a clinician that has a background in working with clients with ASD as well, just to make sure that you are the person that is getting the treatment. There's certain things with autism that can tend to be different. Another thing is, like, sometimes people with autism aren't always overtly expressive with their emotion, or don't know how to articulate their emotion. Once again, this is not putting everybody in a box. This just can sometimes be clients with autistic clients. And so the therapist thinks everything is fine, everything is great. I have a nephew with autism, and it's like when my grandma passed, he was really close. He was verbal about how sad he was, but externally he looked happy, right? He wasn't showing those emotions. So sometimes, unfortunately, like if you're working with a clinician that doesn't work with people with autism, they may not understand certain cues and may be missing a lot. So I will say we're having some guests next month in February that are from the IOCDF OCD and Autism Special Interest Group. So definitely they'll be able to go in more in depth. But from just the work I do, I work with a lot of clients with autism. There's a lot of co-occurring. I don't know if you see that, Adam, as well, but I know we get a lot of co-occurring OCD and autism.
Mm-hmm. Yeah.
Another pre-submitted question was, which medication does not cause weight gain? They went on an antipsychotic. First of all, can you talk about, like, when is an antipsychotic? I think, first of all, that word scares people, but when is an antipsychotic used in OCD?
Mhm.
And then this person was just saying like which medications, because they gained some weight, which medications are known for not causing weight gain.
Yeah. So antipsychotic medications, it's sort of an old term that we still use. There's a few different terms for these medications. Neuroleptics is another one, but we don't just use them to treat psychosis. We use them to treat depression. We use them to treat OCD. They have other uses, but that's the most common name that you hear from these medications. There's decent evidence that for people who have been on an SSRI and had an inadequate response, that adding in one of these antipsychotic medications, augmenting the treatment, can be helpful for some people. Not everybody. Some studies say that maybe a third of people who start an augmentation with an antipsychotic actually have benefit from it. So we have to think carefully about how long do we keep people on these medications before saying, well, maybe you're in the 2/3 that hasn't responded versus, yeah, you're noticing some benefit. I'd say that the two medications that have really sort of the best evidence in that class for improving OCD as an augmentation strategy. Again, so these are people who are taking an SSRI and we're adding in this antipsychotic medication, are aripiprazole, or Abilify is the brand name, and risperidone or Risperdal. And those have, different side effect profiles, slightly different ways that they work. Unfortunately, for that class of medications, the antipsychotics, those are notorious for side effects that are bothersome and in the long term can really be problematic. Weight gain is a common experience. Disruption to metabolic profile, so like increasing blood glucose and lipids and cholesterol. Those are unfortunate side effects of those medications. Within that class, there's some that are more known to cause weight gain. Things like olanzapine and quetiapine are particularly problematic for weight gain. Abilify less so, but as a class, that's a side effect that's known. Within the SSRI medications, those can cause weight gain, usually not on the order that the antipsychotic medications will. So for those, olanzapine, quetiapine, sometimes with risperidone as well, we're, thinking about 10, 20, 30 pounds, sometimes more, that people can gain. Usually for antipsychotics, if people are going to gain weight, for antidepressant medications, for things like SSRIs, you were thinking about a few pounds, 5 pounds, 10 pounds, maybe. I've seen it with it more than that, but that's not typical. And then within the SSRI medications, some are more likely to cause weight gain than others. So things like paroxetine or Paxil or fluvoxamine or Luvox may have a little bit more of a risk for weight gain than some of the other medications like Lexapro, which is escitalopram, or fluoxetine, which is Prozac. But certainly the antipsychotic medications are more likely to have that as a problematic side effect.
All right, thanks for that, Adam. I'm going to take Bear in the Garden's question at 1226. It says, should associated depression reduce as OCD is treated? I'll take the clinical side, and you can maybe talk about like the medication side if somebody's taking a medicine. So Bear, on the OCD side, so typically what I see is people, the DSM says that about, I think it's 68% is the statistic, that somebody with OCD is also going to have a depressive disorder. And we know why, right? Because with OCD, if we're constantly giving into the disorder, our world becomes smaller. So people are not going to school, they're not working, they're not dating, they're not spending time with friends. So that's why we see such a high co-occurring rate of depression and OCD. Now, what I see probably 8 out of 10 times is if somebody is dealing with depression, as they're getting better from OCD, the depression lifts automatically. Sometimes we don't really do anything about it, because one of the things that really helps with depression is what we call behavioral activation. And so as somebody's OCD is getting better, they're starting to leave the house, they're going back to the grocery store, they're driving, they're spending time with their friends, which is activating, which is combating the depression. Sometimes, though, clients get better and the depression doesn't lift. And typically there's a reason behind that. Sometimes it's because somebody is dealing, what we saw earlier with Jane, is like somebody in their life just passed away. I mean, doing OCD treatment is not going to get away the depression and the pain that they're having from a family loss. But typically, if somebody's depression sticks around, it's because they have an incident or an experience outside of the OCD that's really driving the depression. How about on the medication side, Adam? What do you see if people start on
Yeah.
a medication?
I would say I have sort of a similar experience. For many people with OCD, the sort of severity of OCD and experiences with symptoms of depression kind of track together. As OCD is worse, more severe, more impactful, people's mood is worse, their sleep is more disrupted, they're less interested in, activities. Um, and as the OCD improves, those symptoms of depression improve as well. For, I think, more of a minority of people, those two can seem to be sort of independent of each other. OCD can get better and depression can still feel very impactful, or depression can get better and OCD might still be there and still be bothersome. For those individuals, we might again think about whether there's a different class of medications that we could use to kind of augment. If they're already taking an SSRI, their OCD is improving, but depression is still sticking around. Is there something else that we might consider that could help with, some of those symptoms from like a different medication class?
Yeah. I'm going to ask the next question. Maybe you could answer this from a medication side. And then, Emilio, I just put a link in the chat. There is a question from Dr. Hassan at 1233, how to deal with insomnia if you have OCD and general anxiety disorder. So I just did a presentation with a group of folks last Saturday about insomnia and OCD. But what I did is I put, Emilio will put in the chat, Kim Quinlan, who's a good friend of the program, she has a Your Anxiety Toolkit podcast. And actually, Adam Sue Chuddy, who is on a board with us, just was a guest on that. And she talked about insomnia and trouble sleeping. So Emilio will put that in the chat. Please give a listen to that podcast. Sue is trained in what's known as cognitive behavioral therapy -I, which stands for insomnia. So she gives you some really good tools. I'll just say, as somebody that outside of OCD and all this, I do a lot of research and I've been trained as well as Sue on working with insomnia and OCD because I have my own sleep conditions. What I would first strongly say is I thought all of my sleep issues was based on because I have OCD and anxiety, but I found that I have both obstructive sleep apnea and I also have what's called like idiopathic hypersomnia, or IH, which is like kind of daytime sleepiness. So I did in building sleep study. So not the one they come to your house. It was very advanced. You go and you take you sleep and they connect you to all these wires. And then the next day you take these daytime naps and they can really give you information back. So what I like to find out from the client it doesn't mean the client always has to get a sleep study, but sometimes getting some medical checkups is helpful too, to see if there's a reason that you're having some insomnia. But let's say it's for an OCD reason, an anxiety. I typically see that people are up late because they don't want to lay in bed and only be sitting there stuck with their intrusive thoughts. So they wait until they're absolutely exhausted at 2 or 3 in the morning to pass out. So they never have that quiet time with their thoughts. Other times people are really struggling with racing thoughts and they're just sitting there and just thinking about all these what ifs, what could go wrong. And that brings on that cortisol and those stress hormones, which keeps you awake. Sometimes people's exhaustive OCD routines keeps people up late. And then sometimes it's certain sleep hygiene things. People, drinking, a Red Bull at 10 at night and playing video games and up with their friends and active. So what you want to do is find a clinician who is trained in both OCD and anxiety, as well as has some background in sleep. So what I would do with a client is really start to work on some sleep hygiene, starting to come up with tools that we can work on the OCD a little bit earlier in the evening. So by the nighttime, it's sort of settled. You're not spinning on your thoughts. Sometimes sleeping with a sound machine can help like not get engaged with those thoughts. There's sleep restrictions. So some people get in the bed at 10 o'clock and then just lay there all night, but don't fall asleep. You wouldn't just sit at your dinner table 5 hours before dinner. So there's a lot of strategies we can do. But what I will say is what I find for a lot of clients is if they work on the OCD and the anxiety, that there's, just like we're talking about depression getting better, a lot of times people's sleeps get better. How about on the medication side? If you're working with a client with OCD and their sleep is just really, really negatively impacting them, is there some medical interventions that people can do?
Yeah, I think understanding how sleep is impacted is sort of the first step. Is it trouble getting to sleep? Because, as you're saying, Chris, like, anxious thoughts are running through your head and you just can't fall asleep. Is that not the issue? But you get to sleep and then you just pop awake multiple times a night and then can't get to sleep, get back to sleep. Or is it the opposite where you're able to get to sleep, but then you wake up super early and you're just like awake at 4 in the morning? Because the approach would potentially be a little bit different from a medication perspective, depending on kind of where the challenges are. Unfortunately, sometimes people have all of those. They can't get to sleep. When they do, they wake up, frequently throughout the night, and then they just get up at 4 in the morning. Um, if OCD is getting better and those things are persisting, I think it's worth considering, do you see a sleep specialist and have either an in-home sleep test or one of the sort of like in-clinic sleep tests where you're there overnight and then the next day? And then really figuring out, is there something else going on? Is depression a component of it? Is generalized anxiety still there and not effectively treated? If we've kind of gotten all of those things in a better place, there are medications that we can consider for sleep that come from a number of different classes, and some of those are you take them each night, some of those you take them as needed. Those I would think about as sort of like making sure that we're considering all of these other approaches, and not just trying to put a Band-Aid on something that we might be able to better actually fix with a behavioral approach or a therapy approach.
Well said. I wanted to toss this one to both of us. Jane at 1234 says that she's experiencing negative self-talk. Does acceptance with commitment therapy work? She's on 20 milligrams of Lexapro. So that's a question I wanted to ask first is like, is 20 milligrams of Lexapro a good dosage for people with OCD? Is that average? Is that low? And can you talk about the difference about dosing with OCD versus somebody who just comes in, maybe they're having some mild depression?
Yeah. So typically for Lexapro, we're thinking about starting that medication at 5 or 10 milligrams and then sort of making incremental adjustments up, usually on that 5 to 10 milligram scale. And if we're thinking about generalized anxiety or depression alone, 20 milligrams is usually sort of the maximum dose that we would prescribe that medication at. For OCD, we again know that there can be additional benefit for some people at higher doses. So at 30 milligrams, at 40 milligrams, at 50 milligrams, there may be additional benefit. So depending on how long you've been at the 20 milligrams, there may be, if you've just gotten to the 20 milligrams like last week, maybe give it a little bit more time. You might start to notice some improvement. If it's been a while, there may be additional benefit from trying to increase that to a higher dose of that medication.
I would say, Jane, on the treatment side, I'm always working with clients on negative self-talk. I really like the work that, speaking of Kim Quinlan, she has a book out, the Self-Compassion Workbook for OCD. She also has podcast episodes on that. Negative self-talk, I see it so high. I don't know if you see this in your practice, Adam, but people with OCD, people with depression, people with body dysmorphic disorder, social anxiety, like their internal dialogue, and it was like that for me as well, is so harsh. And I think the aha moment for me was I asked myself, how come everybody in my life that I want to see thrive, I'm kind, I'm compassionate, I'm understanding, I can be directive, but it always comes from a place of love. I help them see the error and talk about it being a learning lesson. But as soon as I flip it to myself, I'm putting myself down, I'm harsh, I'm beating myself up. You could have been better. And I think it was like I, for some reason, thought some boot camp way of living was going to make me a better person. All it did is make me depressed, unhappy, shut down, and less likely to achieve the thing I was striving for. So obviously, we can't fix it in this quick live stream, but that's why I really like the worksheets, and it's an interactive book, Kim Quinlan's. And there's other books about self-compassion. Acceptance and commitment therapy is an amazing treatment. Wasn't necessarily designed for OCD per se, but we found it very helpful with OCD. And there's some cognitive diffusion strategies, which I really like because I have a background from martial arts and mindfulness. And so for me, separating myself from the thoughts, that cognitive diffusion was helpful. So kind of seeing like, oh, the barky brain is coming in trying to ridicule me, but it's never helpful. Let's not give it the attention, right? That acceptance and presence of some thoughts that are uncomfortable yet not engaging, and really committing to sticking with the things that matter. So if you like acceptance commitment therapy, there's definitely an OCD workbook. I think it's from I'll put it in the chat before you leave today. It's from a former guest. I think it's Marisa who is written it. I'm almost positive it's Marisa. So I'll put that in the chat for you as well. But there's a really good ACT and OCD book. A couple last questions because I know we're hitting time. Is there any research? This is a you question at 12:41 from Spence. Is there any research that creatine helps with depression?
Good question. I don't know off the top of my head. I would have to look a little bit to see if there's any evidence to support that.
Yeah, you could message me, Spence, at the next live stream next week. I'll just kind of start out and be like, Spence, if you're there, this is what Adam said. The next question is at 12:44. Is Luvox a medication that helps with OCD?
Yes, that definitely is. It's within that class of SSRI medications. Fluvoxamine is the generic name for Luvox. Certainly has evidence to help with OCD.
And then, yes, I just found it. So it is the ACT for OCD workbook. It's a mindfulness, acceptance, and exposure skills. And that is from, let me copy the link. And that is from our good friend, Marisa Maza, who's been on the live stream. I really like her. So I will put that in the private chat. And that will be good. Okay, two last questions and then we'll go. There was a pre-submitted question that says, if you have a side effect on one SSRI, would you expect the same side effect with a different one, or is it worth trying other medication, others before trying a different class of meds?
I would say worth trying another SSRI. They all have slightly different side effect profiles. It also depends a little bit on which side effects. Some of them are sort of more common across that class of medication. So, for instance, for some people, sexual side effects can be really bothersome and prominent, and those are generally, like, if you have it on one, you're likely to have it on the other. The severity might be a little bit different depending kind of on the dose, but other side effects are maybe a little bit more specific to certain SSRI. So overall, I think worth trying another SSRI.
Well said. Somebody said they're taking that barking brain. Anything I say on here, y'all could steal, I promise. Marco at 12:45 says, is it accepted for ERP around contamination OCD to expect clients to do things as exposures that many people without OCD would find difficult or unacceptable? For example, I saw a therapist ask a client to touch a public toilet bowl, not wash their hands, but someone without OCD would likely find that gross. Any thoughts? So this is how I practice, Marco, and I'm going to put this as like a big caveat because I don't want any clinician, I know other clinicians watch this, and I don't want them to think I was like subtly like attacking them. This is not them. This is like my personal opinion. When I was in treatment, one of the things that's always hard in treatment is motivation, because we have so much more motivation to stay stuck because our brain and our body wants us to. So for me, any change or action I took, I first needed a cognitive intervention, because I was not, we're not show cattle, right? To tell a client like the first day, like, touch the toilet. Somebody's gonna be like, why the hell am I touching a toilet, right? So my therapist, we always had like, what errors were I thinking? Why did I get to this point? Like, I do that with clients first. So before we even go and do exposures, they have a good understanding of like, the tricks of OCD. How did they get to this point? Why are they so inclined to be anxious and have a different set of rules? Then when I do exposures with clients, I try so hard to make it something that they enjoy and values based, because fear factor treatment is not going to make anybody happy, right? I'm not trying to like throw toilet water at somebody or like, hey, there's dog poop, let's rub it, because I have to do my exposures with clients and I don't want to do any of that stuff. So I always try to find things that people care about. So an example is, a lot of clients feel like they have to wash their hands before eating, which is fine. A lot of families do that, but all of clients that have like, hand sanitizers and holsters, and it's like before they even eat anything, they're sanitizing. And I'm like, Well, what if a friend of yours is like, hey, try this food? Are you going to grab the sanitizer and do that every time? Or at the movies, before you eat popcorn and you rest your hands, you got to sanitize again. So what I might do with that client is we'll go over to the mall by my office. There's See's Candy. We'll get some samples and eat it. Maybe they wash their hands after the bathroom like an hour ago, but they're not going to sanitize right before. What I find is the client definitely wants to go eat See's Candy, and it feels like a normal thing to just go to a mall and do that, and they see other people doing it. And because they see the purpose of it, I find that really boosts motivation, and it makes people more likely to come to treatment than if I was having them lick toilet bowls. So I don't want to feel like I'm bad mouthing any other therapist that did this. I just say it's not how I practice. I did a talk with Liz McIngvale about OCD not being fear factor. And I really believe that we can get people better without it being a shock and awe treatment, and they'll be more likely to come back. All right, Adam, I'm going to give you final thoughts, but what I'd love for you to weave into final thoughts, I didn't get to a pre-submitted question about TMS. So your final thought, I'm kind of hijacking and making you do a topic instead of a general one that I usually let people do. But on the way out, when does TMS come into play? Because I think a lot of people are hearing about transcranial magnetic stimulation. People are hearing others get better. When do you know, hey, either you have to stop your medication or you can do it concurrently? TMS it's time for that.
Yeah, a great question, Chris. I would say for people who have tried a few different medications, who have tried ERP, who are still struggling with OCD, we have these other approaches to treatment, things like TMS, and DBS as well, deep brain stimulation. There's sort of another level up there. But that's the time to start considering exploring that. And I'll weave that into sort of final thoughts in terms of the role of medication and neuromodulation in treating OCD, and finding a provider who has some experience within that domain can make a really big difference, because you'll be able to get started on medication, appropriate medications. You'll work with somebody that feels comfortable prescribing to the dose that might actually be needed to have you feeling better from an OCD perspective. And then we'll be aware of sort of these other modalities, whether that's augmentation with an antipsychotic medication or referral for TMS, and has experience sort of navigating all of those different domains with an individual with OCD. I definitely think medication can have a role for a lot of people. And then we have these newer treatment options as well that can be helpful for individuals who haven't fully responded to our sort of first line treatments.
Yeah. Any final thoughts? I hope, what are you seeing with the clients that you're working with? Anybody watching this that maybe is down, feeling low or frustrated, or doesn't feel like they can get better? Any final kind of like booster thoughts?
Don't give up hope. There are so many different options. And I have certainly seen people who have felt like nothing was going to get better, and we just adjusted the dose of medication, and that made a difference. Or we adjusted the dose of medication, that did a little bit, and then we got somebody connected to TMS, and that had a really positive influence for them. Or for those people who nothing else has happened, can explore DBS, and I've seen that be really life-changing and effective for people. So there's lots and different approaches to treatment, and I would say just keep plugging along, trying things out, getting connected to people who know about those and have experience with those, so that you're really getting that full sort of range of options for treating OCD.
All right. Well, thank you so much. Emilio in the chat put that link to Marissa Mazza's Act for OCD book that we talked about. Dr. Hassan, the link for the podcast for insomnia, the IOCDF put that in the chat as well. Sue's great. She's going to have resources. So just go to the comments in YouTube and look for the one from the IOCDF with that link to that Spotify podcast. And Emilio just put it back up, so it's right there for you. And yes, Nathan, there's definitely a form of TMS that has a coil that's specifically designed to treat OCD. So make sure you use that. Thank you to everybody that joined us today. This is a community podcast live stream. It's not a podcast. I just said podcast. It's a community live stream rather. And it wouldn't be here without your comments, questions, and community. So thank you to everybody that joined us or watches us on the replay. It always gets thousands of replays. So if you're watching this right now from home and you couldn't make the live, thank you so much for joining us. The IOCDF has a lot of live stream content, not just these live streams on Wednesdays. So make sure to head over to iocdf.org/live. That's a list of all the live streams, or actually /live streams rather, but also the iocdf.org in general to get all your one-stop shop for OCD related stuff. Thank you so much to the IOCDF for having these live streams, for Emilio for running the back end, and for you for coming. And then obviously, finally, Dr. Adam Frank, thank you so much. We are bringing on psychiatrists every second week of the month because people are demanding it. So we'll definitely have you back. But thank you for joining us and sharing your expertise. Everybody, like Adam said, there is absolutely hope out there. Thank you for joining us, and we'll see you at the next live stream. I'll be back next week. Take care.